All right. Good morning, good afternoon, or good evening, wherever you're logging in from. Welcome to the May version of the Australasian Plural Seminar. Today, we have got the pleasure of having Associate Professor Rob Halifax from Oxford, England, to talk to us about pneumothorax. So, pneumothorax is definitely a very hot topic in pro disease world. A couple of months ago, you have Stefan Marciniak talking about the genetics, and today we're going to focus on epidemiology. And Rob has published quite a few papers using very big data sets. One of the advantages of being in England uh, to tell us a lot about information that we love to see. And I'm sure a lot of you, like me, quote a lot of those data, especially in every introduction of pneumothorax paper in the and grants in the introduction sections. So, welcome, Rob, and the floor is yours. And let me just remind the audience, if you have any questions, please put it on chat as we go along. Thank you.
Great. Thanks very much, Gary, and thanks to the organisers for inviting me. Apologies in advance for my slightly croaky voice, but yeah, I'm Rob Halifax from Oxford, and my pleasure to talk to you today about pneumothorax, particularly about the epidemiology of pneumothorax. So I don't think I need to explain to you all what a pneumothorax is, but I hope you can see on the left-hand side of the screen here, right-hand side of the patient, a large pneumothorax with lung collapse. There's lots of debate in the literature about how best to manage these, and we still have the same sorts of debates. But what I'm really going to talk to you today about is the incidence. So how often this is happening, how often it ends up resulting in an admission to hospital, what the trends in those admissions have been over the last 20 to 40 years, and how those have been impacted by recent events of COVID and new guidelines. What's the latest data on recurrence that you can talk to your patients about at the risk of recurrence, and some more recent data on mortality for those patients who do end up getting admitted to hospital. So looking at the incidence to start with, so this is a combined table from a number of different papers, including, oh, what's happened here? It's all right. Can you still see that? Okay. Yeah. This is a combined paper, so looking at rates per 100,000 of the population for admissions to hospital. So in England, this is a paper I published in JAMA back in 2018. We found that overall, this resulted in 14 per 100,000 of the population per year, and which is with a male predominance, so more males than females. And this was matched quite nicely by a group who published on Germany from their national data set. Bobbio in France published around the same time, and they found a slightly higher incidence rate. But interestingly, Korea, they published some national data suggesting a much higher rate. Now, this is very much driven by the young males, and we'll talk a bit more about that particular population in a minute. But there seems to be a significantly higher population in Korea. Now, these are incident rates of admissions to hospital, so it may be that actually this is slightly skewed depending on how people are managed, whether can conservatively managed patients coming through A&E and not being admitted may not enter into this data set if they don't get admitted to hospital, but actually if there's a difference in management in Korea, then that might be driving some of the numbers here. But I'll be interested to see what you guys think about that difference. Sorry, I'm still getting an issue with this screen. Sorry, excuse me. I hope you can still see that okay. So a USA paper suggested a slightly lower rate in the US, which we don't quite understand. But overall, most of the sort of Western European countries are reporting around the same sort of rates. When we look by age group, we see this classic bimodal peak. So a peak around the age of 20 to 30, and then a nadir around the age of 50, then raises up again once you get over 65. And this is very pronounced in men, and a higher predominance overall in men. And when we divide that by whether patients have got an underlying, so that's in England, and a similar looking story in Germany. These number of cases rather than rates. So the scale as you get towards the top end is slightly different, but actually the similar sort of bone major peak for males. Not quite so pronounced in females. You don't get the same nadir around the age of 50, but overall it seems to be fairly similar. And when we split that by whether the patient's got any evidence or record of any underlying lung disease, then we do see quite a difference. So we did this in our national data set looking on the same admission up to 12 months before or 12 months after. If they had any record of any underlying lung disease, we called it secondary, and if they didn't, we called it a primary. And you can see that the vast majority of these young males in the 20 to 30 don't have any underlying lung disease, and we call these the primaries. And in secondaries, it tends to be more about in the elderly population having the secondaries, but there is a little bit of overlap. So how we did this? Well, we looked at 170,000 admissions to looking at that data over the course of up to 40 years worth of follow-up, looking at the trends. And when you look at the trends here by age group, there does seem to be an increase in males, particularly over the age of 65. But this was really marked in the females group. The red line on the right-hand side here, you can see that the over 65 group seems to be markedly increasing in females. And overall, that's resulted in an increased admission rate from in 1968 from 9 per 100,000 up to 14 per 100,000. So an annual percentage change of only 0.5, but that's been pretty steady over the time period. When we look at the group in Korea who published, again, they do see an increase in the over 65s, but they've seen them, unlike in Europe, they've seen a marked increase in the 15 to 30-year-old group, which again, as I mentioned, had a much higher rate of incidence of admissions in Korea than compared to Europe. So that's where we were up until 2018, and then the world stopped. Things changed a bit. We had COVID, which changed the world for a while. But we also had this large paper published by Brown et al. On conservative management of primary pneumothorax, being run out of Australia and presented at the BTS here by Gary, and has made its way into the new BTS guidelines published last year, where we give more sway to patient choice, more evidence about conservative management for minimally symptomatic patients, and also an option of ambulatory care. So there's lots of reasons why these patients may have had a step change in their management, either through COVID or through choice about conservative management. And as I say, that paper was mainly driven through Australia. So we were wondering whether there'd been a change in practice. So I'm sure some of the listeners in here will be well aware of these papers in Australia. So one was looking in a single centre in Queensland to look to see whether there'd been a change in the management of primary spontaneous pneumothorax before and after that Brown paper I mentioned. Now, small numbers here, but they looked before and after 2019 when the results came out. When the practice of intervention changed from before and after, so 33% had an intervention before, whereas now it's only 12%. So certainly in some centres there has been a change. And Kelly et al. Did a large survey across Australia and New Zealand with 450 respondents, 85% of them were Australian. They surveyed a number of different disciplines, so emergency medicine, radiology, respiratory, or pulmonologists, and there was still quite a variation by discipline. And most all of the participants in the survey said that they would be guided by the patient's vital signs as to whether they were going to intervene or not. But when provided with different scenarios, which altered slightly depending on what the size of the pneumothorax was, there was an increasing percentage of intervention based on pneumothorax size, which goes slightly against what we saw from the results of the study. When they asked about the guidelines, the guideline awareness was pretty low, except in pulmonologists where they were very aware of the new BTS guidelines. So I wanted to see whether that step change, well, there had been a step change around COVID, and whether actually we're managing fewer patients as inpatients now. So we then updated this going from 2017 up to 2023 to see if there'd been a change there. So we looked at all the hospital admissions in England across that time period. We filtered those for spontaneous pneumothorax, and when we highlighted only the emergency admissions and those with the pneumothorax as a principal diagnosis down the bottom here, we still had 40,000 admissions over that time period, just under half being primary and just over half being secondary. And when you plot this over the time period, with the pneumothorax being as the main diagnosis, so the main reason they come into hospital, you can see it being fairly flat over the few years overall, and then a big dip down around the grey bars here, which were COVID. So patients weren't presenting with a pneumothorax as the main diagnosis around the time of COVID. I imagine people were purposefully choosing conservative management, either knowingly or unknowingly. But then it comes back up again after COVID, almost to the level where it was before. And certainly once you look at primaries and secondaries, it seems to be fairly flat. When you look at pneumothorax anywhere on the record, so not necessarily the reason they came into hospital in the first place, we do see this big spike, particularly around the second wave of COVID in England, which was middle and end of 2021. And if we focus down on the bottom corner here, where we divided into primary and secondary pneumothorax and COVID related, you can see that the vast majority of those admissions with COVID anywhere on their diagnostic codes was related to this big spike here, which is COVID related pneumothoraces. Whereas actually the primary and secondaries, once you exclude those with COVID, have remained fairly flat. So we don't seem to have seen a big step change either after COVID directly, where fewer patients were being admitted, or in 2022, 23, when the results of those big papers were coming out. So we haven't seen a big step change since 2019 in terms of the admissions to hospital. We're still seeing just over 200,000, also 2,000 admissions per year with primary pneumothorax and just over 3,000 admissions per year with secondary pneumothoraces. And that doesn't seem to have had a big change. Although anecdotally, that seems to be tricky when you're trying to recruit to pneumothorax patients to our trials at the moment in the UK. So that's about the incidence. What about recurrence? So again, we looked at that UK data. We looked over a 40-year period, looking initially at primary spontaneous pneumothorax here in the males. Sorry, males, we've got primary and secondary. When you go out to 1 year and 5 year, overall recurrence seems to be around 13%, but up to 20% in 5 years for primaries. Secondaries is significantly higher. So if you've got a secondary pneumothorax, your chance of recurring is almost double. But there's a significant number of patients that do seem to represent within 7 to 30 days. Now, you could argue whether the 7 days is truly a new event or whether it's a non-resolution of initial event, but certainly it does result in a significant number of patients coming back in again. So you could argue that actually, if after you've survived the first 30 days, your rate of chance of readmission actually sort of levels off slightly up to a year and then increases very slowly up to 50 years. So most of the recurrences do happen within the first few months. And we get a very similar looking picture when we look at females as well. We know the overall incidence is lower, but in this data set, the recurrence seems to be around the same. Again, much higher in terms of the secondary pneumothoraces, but a significant portion happening within the first 30 days. And actually, that's in line with what they've found in the Brown paper, looking at conservative management. They found around 12% overall recurring at a year, but a significantly lower proportion happening in the conservative managed group compared to the dotted line, which is the interventional group. So that those two studies are in line. But if you use all the previous interventional studies and look at the meta-analysis as Steve Walker did from Bristol here, again, a significant number of patients here, 13,000 patients over 29 studies. That meta-analysis suggested a higher recurrence. So 29% of patients overall with pneumothorax were having a recurrence at a year, and 32% if you extend it out to 2 to 3 years. So a slight discrepancy there between the interventional studies and some of the bigger epidemiological studies. But one of the interesting things they looked at there was that looking at risk factors for recurrence, and they found that although the incidence is lower in females, if females do have a pneumothorax, particularly primary pneumothorax, the odds of recurrence is higher. And if there are smokers, as we know a lot of the young primary pneumothorax patients are, if you stop smoking, that actually actively reduces your risk of recurrence. So I think it's an opportunity here to talk to our patients about smoking cessation, and it seems to make a difference. Now, what about mortality? Now, we know that those patients that do get admitted end up staying in hospital for a significant amount of time, and there is a significant mortality risk here. So this is data from France and the US to start with, and we can see similar sorts of data. For primary pneumothorax, once they get admitted, they stay in hospital for about 5 days. Secondary pneumothoraces tend to be a bit longer, up to 8 to 9 days, but the mortality difference is pretty marked. So less than 1% of those without an underlying lung disease seem to have an inpatient mortality. In primary pneumothorax, for secondary pneumothorax, a significant mortality rate. So 7% here, which is pretty much matched by those with an iatrogenic pneumothorax, who also stay a bit longer. So that was some older data from France and from the US. But I wanted to update that with some data from England. So we looked over the last 20 years at the Office of National Statistics death records, and we found 6,500 deaths which were related to pneumothorax. The majority of those being in-hospital deaths, but 81% of them had an underlying lung disease also listed on their death certificate, and the most common one of those was COPD, as we may have expected. When we look at pneumothorax-related deaths, the overall rate here is up at the top, and is really dominated by the secondary pneumothoraces. So the light purple here is the overall secondary pneumothorax deaths, and then the light blue one is the in-hospital secondary pneumothorax deaths, whereas this primary group is right down the bottom here. So even at that rate, with pneumothorax related, it's very much driven by the secondary pneumothoraces. And even in the primary spontaneous pneumothorax groups, once you break it down by age, you see that actually the younger group, the risk of death is really low. And those patients over 65 who haven't got a diagnosis of an underlying lung disease are the ones that are most likely to die in hospital. And this is, again, mimicked with the secondary pneumothorax group. Sorry about that. So when we look at the pneumothorax specific death rate, so these are where the cause is definitely related to the pneumothorax, we can see that actually the trend here is overall improvement, as we did see in the previous slide. Although most of the deaths are in the over 65 group, there is an improvement in the number of patients dying per million across the years. And that's certainly marked when you look at the pneumothorax specific death rates, albeit with a big spike around the COVID time period. So that was when that's looking at the death records alone. Now, what I also wanted to do is look at the admissions over that time period, and then see how many of those ended up with a death rate, so we could see what percentage of patients who come into hospital with pneumothorax ended up dying. So over that time period, we had a large number again, so 200,000 pneumothorax-related admissions, and actually a significant number of those ended up with an in-hospital death. So 13% of patients end up dying in hospital if they had a pneumothorax on their coding, but only 2% of those, or 2% overall, were certified as pneumothorax related, and an even small amount were pneumothorax specific. So only 400 over that time period was specific to pneumothorax. So if you come in with something else and you develop a pneumothorax related to an underlying lung disease, you've got a significant chance of death, but actually it's unlikely to be listed as pneumothorax specific, which makes us think, well, actually, how accurate is that coding? So from 2017 onwards, so about half the time period we've got, we can look at the order of the coding that gets put on the death certificate. So in the UK, you get part 1 and part 2, and part 1 is the sequence of the conditions leading to the part 1A, which is the main death, and part 2 are related causes. So in 8% of them, the pneumothorax was the underlying cause, but actually in 64% of the time, it did appear in the sequential list of conditions leading to death. So I think if you just look at underlying cause, you probably underestimate the impact that pneumothorax has within these patient groups, because actually it's listed in the sequential cause up to 64% of the time. So I've gone over my 15 minutes slightly, but I've talked to you a bit about the incidents here, about the trends, and overall we were seeing a slow increase in admissions up until 2018. There was a sharp spike in admissions of COVID-related pneumothoraces, but there doesn't seem to be a step change down again when we're looking at the new guidelines post-COVID. When you're talking about recurrence, there seems to be some data that the recurrence is higher in females, and there is an advantage to stopping smoking. And in mortality, it's certainly marked much higher in the secondary pneumothorax group, particularly in those over the age of 65, but it may well be underestimated when you look purely at the death certificates for pneumothorax related rather than underlying lung disease. So I'll pause there and happy to take any questions.
Excellent. Thank you, Rob. That's a lot of big data, and I think we've learned a lot from that. And I think, was that your son there? I think he must be the youngest ever participants in the TAP series in the last 3 years. It's good to have young people coming up the generation. While people start typing the question in chat, I might start first. So one of the very intriguing questions I always have is, as you alluded to, once people have a pneumothorax, the recurrence seems to occur quite soon afterwards. Whereas if you think that, if primary spontaneous pneumothorax is a developmental thing, they would have it for a long, long time. Why did it suddenly occur in a certain time, and then why didn't it keep occurring in the next 12 months or 5 years? Any thoughts?
Yeah, it's a good question. I don't think we've really got an answer to that. So I guess your question is if your risk is the same because it's a genetic problem or a developmental problem, your risk should be the same throughout your whole life. So you shouldn't get a peak early in the recurrence, within the first few months. And why does it then taper out to a plateau? I think my increasing view is that there is this predisposition. There's some developmental thing or something or genetic susceptibility, but you have to have some other hit as well. So in some patients that will be smoking. I think there's a bit of data now linking some pleural so lung infection as well. So even a low level viral infection, which leads to a slight increase in inflammation, which leads to a slight weakening of the pleura perhaps, and that insult that happens at that particular time perhaps infers an increased risk, certainly in the short instance when they have the pneumothorax episode. But I think that inflammation may go on maybe for many months, and so actually that's the time hit that they have is in the first few months of that, and then once that other insult goes away or they stop smoking, actually their further risk reduces. But I think at the moment it's a bit hypothetical.
Right. The first question online was, what is the mortality from primary spontaneous pneumothorax actually due to, as opposed to other causes of death?
Yeah, so good question. So I think with the true primary pneumothorax group, I think the death rate is pretty low. So it's less than 1%. And I think that's certainly is more marked in the over 65s. And I think there's always a debate to be had about, once you get to over 65, is it a truly primary spontaneous pneumothorax? Now I think there's all these patients we're calling primary, which is supposedly have no underlying lung disease. There must be some pleural abnormality that causes this inflammation. I think that's more marked, or your ability to cope with that becomes much less marked physiologically as you become older. So the majority of those patients do die of a respiratory failure or a superadded infection while they're in hospital being treated for pneumothorax. We know that if you've got a lung collapse, there'll be some atelectasis there that puts you at increased risk of developing pneumonia within that lung that's down. And so most patients are either dying from a respiratory failure or it's a superadded infection as well. There is a significant minority of patients who do have a cardiovascular risk there as well, but it's usually it's normally a pulmonary infection.
And seeing the trend that it kind of decreases in recent years, how likely would it be because we now do a lot more CT scans on people, so they're not so primary and moved some of the primary into secondary because we can see them on CT rather than just chest X-ray.
Um, so that I guess that'd be a trend if that was only happening in primaries, but we've seen a significant decrease in mortality
Okay.
in the over 65s in the secondary group as well. So I think it's not just about shifting the diagnosis to more secondaries. I think it's the fact that we perhaps are hopefully managing people a bit better, being more wary about having other underlying um, comorbid conditions that develop during their admission.
Right, there's a long question in here. It says, "Thank you for the great talk. I recently seen a young patient spontaneous pneumothorax for a third time ipsilaterally with heavy workout in the gymnasium, and also he does vape. He stopped vaping for a period and then restarted 3 months later, and the spontaneous pneumothorax occurs." Um, I'm not sure exactly what's the question, but I presume it means whether you think that heavy exercises acts to one of your precipitating factors and vaping as well.
Yeah, so I think there's certainly case reports of anything that's kind of raises intrapleural pressure, yeah, and Valsalva movements do seem to predispose people. Yeah, there's case reports of people using wind instruments, or if you're in fact even if you're too close to a really loud speaker at a festival, the change in the pressures can cause a pneumothorax. Now they're small numbers compared to the primaries we see coming into hospital, but it's certainly anything that increases your pressure in your chest can precipitate it. Now, I think that happens in people with completely normal lungs and normal pleura? Probably not. I think, as we mentioned before, there's probably has a genetic or a developmental predisposition for having a primary pneumothorax, and then one of these other things will happen. So you'll have some other insult, and then you'll be blowing into your trumpet, or you'll be straining in the gym, and that's when it happens. It very rarely happens completely out of the blue, although we do see that. But I think vaping is almost certainly going to be a factor, and I think in the years to come, when we get better coding for vaping, I'd love to look at that again, because we know smoking is definitely an insult, and if you're looking for the second hit in a one of those two hit hypotheses, smoking is definitely there. One of our randomized control trials, we had two-thirds of patients were either current or former smokers, whereas actually the baseline population smoking prevalence in that group is less than 5%. So you've definitely got an increased risk if you're a smoker, a tobacco smoker, and I think vaping probably has a similar thing. Inhaling the smoke from a vape, I'm sure is not going to be good for the inflammation in your lungs. So I think he's putting himself he's probably got some underlying risk. He probably then vapes, increases the inflammation, and then the Valsalva movement while in the gym puts him at increased risk.
Yeah. Professor David Lamb, who is our immediate ex-president for APSR, is asking, do you see any relations between primary spontaneous pneumothorax treatment, observational chest drains, paradesis, etc., and subsequent recurrence? I might give my version of it, and then Rob can add to
Yeah.
that. So in the New England Journal paper, the 1 year recurrence rate was 8 or 9% in the conservatively managed group, and twice as much, about 17 or 18% in the ones who has drained. And we should have the 5 year follow-up data very soon as well. Yeah, Rob, your turn.
Yeah, I think that's really intriguing data actually, and I think one of the big questions that you we always get is is intervening actually somehow prolonging or extending the air leak? Now, I think at the moment we still offer patients who are symptomatic treatment if they wish to, but the new BTS guidelines very much are putting the emphasis on a stable patient choosing either conservative management, or if they don't want to have the symptoms but want to be out of hospital, we can do an ambulatory management. But actually, a lot of the time you think actually, well, if I hadn't have put a drain in, then would this patient still have an air leak? in 2 or 3 days, actually, when they were quite stable. And I think the data that you presented in the Brown paper, I think, is really intriguing. That actually, even large pneumothoraces, if you don't intervene, it does seem to be a significant difference. As I mentioned, it not all of the data lines up exactly in terms of recurrence rates, and we did see there's a lower than expected recurrence rate. But as I mentioned from the UK data, overall, yeah, we'd expect 14-15% of a young primary pneumothorax recurrence rate. So it's not too different. And it may be that all the meta-analysis that Steve did was all interventional studies, and actually
Yeah.
by somehow intervening, we prolonged the leak, which is an interesting one.
And there might
If
be
they
a
ask
publication bias on there as well. Yes. Yeah.
exactly,
The
but
next question.
if you ask
Sorry,
me,
go ahead. Yeah.
they were talking about talc as well. So I guess that's intervening versus not. I don't think we don't know there's a big difference between aspiration versus chest drain. I think we sort of lump all the intervention together. If the question is about talc as well, we know that doing a talc your VATS pleurectomy and then talc reduces your risk down to 1 or 2% post surgery. So that we know that is significant. You're actually intervening to pleurides.
So next question I won't answer. I'll leave it to you because it's a difficult one. How long do you advise your patients not to do exercise after the spontaneous pneumothorax?
That is tricky. I'd love it if someone could come up with some good data on this one. I think we need some really high quality observational data to start with. I think the impact of it is probably pretty low. So I think if we were going to do a sort of an active study where we told half the patients to stay still for a month and half the patients to start working again, any difference we'd see would be really small. So we'd have to be doing thousands of patients. I think in reality, what I do is I like to see the pneumothorax is resolved. So I think once there's if there's a still an ongoing pneumothorax, yeah, they can walk around and be active, but I wouldn't do anything that has in the gym has a particular Valsalva maneuver because I think that does increasing the intrapleural pressures risks, I think, worsening a potential air leak. But once the pneumothorax is resolved, a bit like flying, really, I think we say within a week, I'd say get back doing some gentle work again and just build it up slowly. Often some patients have a few little twinges after they had a pneumothorax anyway, and I think as long as they're sort of managing that slowly and those still fade away, I think after a week or so they can get back to their usual activity.
Yeah, I think we probably say the same thing. And to be honest, most of the young people will started going back to doing their normal daily activities, regardless of what we actually say, is when they feel well enough to do that. So I think we are almost 10 minutes over time. So I'm just going to stop here. And thank you so much, Rob, for joining us today, especially at 6 a.m. in London, in Oxford time. Let me just advertise for next month. We on the June 3rd, we're going to have Dr. Ken Chen from Chinese University, Hong Kong, to talk about the New England Journal evidence paper that his group just published. Very exciting and seems very promising new tests on TB pruritus. So see you then, and thank you again, Rob, for joining us today and showing all your exciting data. Thank you.
No problem. Thanks for the invitation.
Bye.
Thanks, everybody. Bye.